So if I just decided I'm benevolent like that, I give you $1 billion. What would you change? What would the first thing you try to change?
I'd start with Mbagathi and Mama Lucy. I work in Mbagathi.
Yeah.
So we'd equip our hospital. We'd build our pediatric surgical unit and extend the same grace to Mama Lucy.
Yeah.
And then other counties. Kenyatta is set. So that we don't have to refer all the time. And right now that we have a bit of issues with the bed capacity and the SHA issue, we're unable to refer patients. So now, and if you're unable to sort them out at our facility, where do we take them?
Yeah. Okay. That's wow. Hi. You might have heard the story of Akrit Jaswal, who by the age of 10 months old, yes, as a baby, was already walking and talking. And by the age of 2, was reading and writing. By the age of 7, had performed his first surgery. But somehow, that's not what we're talking about when we talk about pediatric surgery. Welcome to the Med Squad podcast. I have an actual pediatric surgeon here, Dr. Yvonne Olang. I'm sure you didn't start at age 7. But I don't know if you had ever heard of that young man called Akrit Jaswal.
No, actually.
He holds the record for being the world's youngest surgeon. Performed the surgery at 7. And I was thinking, when you're talking about pediatric surgery, that's not what we mean. We don't mean the children become surgeons. But what is the difference between pediatric surgery, or what is pediatric surgery? And is it different from, is it adult surgery, I guess?
Thank you for the intro, Facey. Okay, to start off, as pediatric surgeons, we like actually saying, it's true, children are actually not little adults. Mm-hmm. Everything is different with children. From their anatomical and physiological, they have unique characteristics. Mm. So we require little instruments, specialized technical procedures, and also their fluid requirement, their medication is all calculated differently. Yeah. Imagine operating on something as little as your finger. Everything is quite different. Yeah.
What age of patients do you deal with in pediatric surgery?
Things have actually evolved. Currently, we started from the womb. We have fetal surgery. It's a branch of pediatric surgery.
Surgery before birth.
Surgery before birth. So we do minimally invasive procedures or even exit open procedures just to reduce the severity of the congenital issues and also to improve outcomes. But what most people know, this starts from the womb, but what most people know is from at birth. There are those congenital conditions that need to be sorted at birth, the children born with abdominal wall defects, and this starts from day 1, day 0 of birth.
Yeah. So apart from that, what are the more common conditions that are dealt with, or most common conditions dealt with in pediatric surgery? Okay,
the most common indications for surgery that we deal with are the umbilical hernias, the inguinal hernias, or a parent who wants circumcision for their children. But it's actually subspecialized. We have actually vast reasons for requiring surgery in children, from the congenital conditions, and then you can subspecialize it further to the colorectal conditions, urological conditions. Mm-hmm. The colorectal conditions will be the children born without anus, where we have to divert stool and recreate the anus. Yeah. And then for urological conditions, we have children born with abnormal urethral opening. Yeah. It's not at the tip, it's somewhere on the ventral side. So it's actually a vast majority. If you go to hepatobiliary, we have children born with biliary atresia, which is something congenital also. So
biliary atresia.
Yes.
In normal terms, what would that be?
Biliary atresia is now when your biliary system, your bile ducts.
Oh, the bile ducts.
Yes, they're obstructed or they didn't develop well.
Yeah.
So there's no normal flow of bile from the liver excretion to the gallbladder and all the way to the intestine. That pathway is disrupted.
Yeah.
Yes.
Now, there's one you mentioned that I can go short. Children born without an anus.
Yeah.
So what happens? Is it that there's no opening, or the system, the tract did not get to how does that happen?
So that's in anorectal malformations, and they're different in terms of boys and girls. They present differently. And now in anorectal malformations, actually the anal canal is what failed to develop, and the rectum didn't get towards the anal opening. So we recreate that pathway. The rectum actually arrested development somewhere close to the anal opening, or sometimes high up.
Yeah.
Yeah.
Okay.
So for those children, it's just like an obstruction. There's no way you can eat and then fail to excrete. You have to excrete from somewhere. So the first thing we do, we just have to stabilize the baby, and then we create somewhere for stool to come out temporarily, and then later on we do the definitive surgery. And in those children, their malformation is associated with other congenital malformations, which you also have to rule out.
Yeah.
Yeah.
So this is almost like a reconstructive surgery or sort.
Yeah, you can actually call it that.
So it's all counted in there. So when it comes to pediatric surgery, patients are not small adults. They're actually children. Their bodies are different, but also their setup, the emotional setup or their social setup is different. They have parents and guardians who are worried and panicking. So for you, the delicate nature of the job takes on bigger consequences when that is considered. So which skill is more important, the technical skill or the emotional resilience, or the soft skills like dealing with the context of pediatric surgery?
I'd say everything. You have to know how to calm a nervous parent.
Yeah.
And you also have to know how to handle delicate tissues.
Yes.
And you have to also ensure that your little one doesn't miss a heartbeat. Everything has to marry each other. You can't have one without the other. Everything has to come into play. You have to marry everything. You can't have one without the other. You have to calm the nervous parent.
Yeah.
You also have to have technical expertise to work with delicate tissues for children. And you have to ensure that your child doesn't miss the heartbeat. So you need everything together.
Yeah.
You can't say that you'll be good at your technical expertise while you don't know how to calm the parent, because healing involves, every team has to be on board. Yeah. Once the parent is calm and you've explained everything and reassure them, can also be comfortable enough to actually perform and do the best for the child.
Okay.
Yeah.
And does that also include the team that you work with?
Yeah.
Yeah.
It's a team. We have the anesthesia team, we have the nursing team, we have the theater support team. We all work as a team. Yeah. And if one team is not comfortable, the other team can't progress. Yeah. Everyone has to be happy on table. Yeah. In theater, everybody has to be happy.
Do you have to be some sort of artist, like have a very steady hand and also understand the anatomy, so that you're pretty much, it's like creating a sculpture. So do you have to have that kind of ability?
Yeah. You have to have precision, yeah. You have to have it.
Yeah.
Yes.
Wow. So right here on the Med Squad podcast, when we come back, as we talk to Dr. Olang on this topic that is very, sometimes you get goosebumps just thinking about it. We're going to actually talk about access. Stick around. Welcome back to the Med Squad podcast. You're with me, Yafesi Musoke, and I'm hanging out with Dr. Yvonne Olang as we talk about the access gaps and possibly even real life stories with regard to pediatric surgery. So what you mentioned is highly specialized. It's probably not that common, or how accessible, should I say, or available is pediatric surgery in Kenya, East Africa, or at least we can start with Kenya.
Okay, in Kenya, what I can say right now, we are not where we used to be. We're still playing catch up, but we are much better. We have pediatric surgeons at least in a few of the counties, stationed in the different public hospitals in the different counties. We're not yet many, not a good number, I'd say, but we are somewhere where we never used to be before.
Yeah.
In terms of the facilities being equipped for pediatric surgery, there we are still lagging behind. We're still pushing the government to equip our hospitals with what we need for pediatric surgery.
Yeah.
So there we are still. The big gaps, the equipments, from sutures to machines to medications to equipping, the theater to just serve for pediatrics, and also to have the same in terms of our wards to just the intensive care units. Like for example, in Nairobi County, we are fortunate enough from Mbagathi, we have a neonatal ICU, but we still don't have a pediatric ICU. For neonatal ICU, we just cater for children less than probably 3.5 kgs because it's neonatal ICU.
Yeah.
What about the other children who are older, the infants, the 1 year and above? We need a pediatric ICU in our government facilities.
Yeah. So the equipment that you're talking about, are we sharing like with adult facilities, whether it's scanning machines or ICU?
No, currently what we are unable to do in our government facilities, we refer them to Kenyatta Hospital. Kenyatta Hospital is very equipped to handle everything. It has the ICU, it has the pediatric ICU, it has everything there. Yeah. So what we are able to do in our government facilities, we refer them to Kenyatta National Hospital.
Okay.
Yeah.
And so there's this whole the issue of compartmentalization. So it's easier for some people to operate on something you're not attached to. So like it may be assumed people who work in medical fields with children, it's easier if you don't have children of your own. Or is there a way of compartmentalizing to separate the profession from the emotion? Because children can really tug at your heartstrings at work.
Okay, that's a bit personal. Trying to think. I have 2 children. And okay, when I'm at home, I'm a mom. When I'm at work, I'm a doctor.
Yeah.
And I'd like to give the best. How I'd treat my child is just the same output and input I'd put towards the children I encounter and treat every day. So there's a thin line. There's work and there's, you have to, and also you have to know your why. If that your goal is to change lives or make the child better, somebody has come in an emergency and you want to save a life, everything focuses on that particular case you have at the moment. Yeah.
So in terms of
you just have to know how to separate the two.
So in terms of saving a life, or in terms of the work, is there a particular case that's stuck in your mind, stuck in your memory, like is a really memorable case?
There are many. I'd start with, when I was still in school, we had conjoined twins all the way from Busia. And we had them in Kenyatta, in our ward, our surgical ward, because, what happens first when they come in, we stabilize, and see if surgery is possible or not.
Yeah.
Anyway, and you also have to wait for the baby to grow, for the tissues to also for the baby to grow so that you're able to do the surgery. Anyway, this particular conjoined twin stayed with us for a year. I think we even celebrated their birthday there. But unfortunately, we lost them. They also had congenital heart anomalies, which couldn't keep up at one point. Yeah.
For a year.
Yeah, for a year. In the ward, for a year.
That's the kind of attachment I'm wondering, because that's like you're saying goodbye to people you've got to know. Wow. Was that a tough one?
Yeah, it was emotional. It was tough.
Yeah.
You see, for the mom, there was what the society thought about now having conjoined twins. That was also another issue we had, because also going back home she was being faced with a lot of how the community would accept her back home. Yeah, so it had a lot of things involved.
Have you faced resistance, like whether it's cultural or whatever beliefs, or maybe just fear to surgery, or cases where like this child needed surgery, but there was sort of resistance, or some sort of skepticism?
Okay, for that there's a particular patient I met who came from Sudan. Now for them, they didn't understand why their child was operated on. For them, they didn't think that children are meant to be operated on. Like, you can't do surgeries on babies. So actually she just flew all the way to Kenya to confirm if that surgery was warranted. And she was actually on her way to sue the doctor for operating on a child, because for her, children cannot be operated on.
Yeah.
So just got to understand what the issue was with the child at that time. So we explained to her. The good thing, she had all the documentation, and the doctor had everything. She had everything with her. So, and everything was necessary. The operation was actually needed. He saved the life of her child. So we had to just explain the whole thing and just remove the misconception she had that children cannot be operated. And going back to, we do this from when the child is in the womb, and also from day 0 of life.
Yeah.
The child needs surgical care.
Now, you had mentioned earlier that technology has advanced to the point where you can operate on a baby inside the mother's womb. How does that happen? Isn't that like performing surgery on 2 people at once?
Okay, for that we have minimally invasive procedures. We call them fetoscopic or image-guided procedures. Now for children, I could give an example for a child who was screened early with a congenital diaphragmatic hernia. You do probably procedures to tracheal occlusion, just inserting a balloon through the image-guided procedures. Yeah, technique.
The mouth.
And now,
where the balloon, where is it inserted?
Image-guided procedures. So you insert these things using an image, which you're able to visualize from the mother's. You're able to visualize the baby from the mother's womb and insert these things through imaging.
Yeah.
Yeah. So there's a screen where like if it's an ultrasound, there's usually a screen you can be able to view, and then you can able to insert something through the mother's womb into the baby.
Yeah.
Yeah.
Hey, that's where the precision comes in. Proper precision. All right. Right here on the Med Squad podcast, as we talk about pediatric surgery, we'll be looking at some of the myths, but also looking at the future when we come back. Welcome back to the Med Squad podcast. The future is already here, and that's what we want to talk about. With regard to something that you yourself are also passionate about, talking about training and advocacy, because it's a team thing. You're not here as a solo operator. So, what needs to change if we're looking to build the next generation of surgeons? What do you feel needs to be either changed or improved on or implemented?
Okay, in as much as you can be good with your hands, you cannot be in every OR.
Yeah.
So that's the reason why advocacy comes. You need to educate everybody from the community so that these conditions are able to be picked up early and referred early. So there's no late referral of the patients to improve outcomes.
Yeah.
And we're also able to educate or also advocate towards the government side so that our facilities are equipped. We have what we need for the children. And we are able to also mentor the junior doctors or other colleagues on what to do in case of an emergency, so that someone's child somewhere didn't fail to get care because this emergency procedure was not be able to be done. So we're able to mentor the other colleagues from anywhere you are in Kenya. Yes.
Okay. So what is the biggest, I don't know whether it's a myth or like the misconception about pediatric surgery that you may have heard?
The biggest misconception, I think what I said earlier, children are not little adults, because people tend to really miss that point.
Yeah.
Yeah.
The bodies are not the same.
The bodies are not the same. Even in case of trauma and just everything from trauma, from medications, from fluid requirement, they're not the same with the adults.
Yeah.
Yeah.
Is it in terms of size, resilience, or even things that haven't hormonal? What is it that's?
Children are able to compensate. Actually, they're able to compensate well in case of it. If this was a traumatic accident, a child is able to compensate well that compared to an adult. But you're meant to take care of the vitals and be keen to see any change, because once anything changes, they go down very fast.
Yeah.
So they compensate very well, but in case anything changes, everything goes down also very fast.
Wow.
Yeah.
Hey, that's a huge difference. Now, when it comes to pediatric surgeries, you mentioned quite a few of them, or different types of surgical interventions. So, what do you wish parents knew?
As I always say, to trust their gut. You know your child better. If anything feels off, you speak up.
Yeah.
Yeah.
Trust your gut.
Yeah.
Are all surgeries, you mentioned quite a few, surgical intervention. Some of them I didn't understand. You used the nice technical terms, which is fine. But are all pediatric surgeries available locally, or do we have to refer some of them elsewhere?
Currently, I think we are able to do everything here in Kenya.
Yeah.
Kenyatta Hospital is actually equipped with the very best pediatric surgeons I know. We do everything from, I told you, we now subspecialize from hepatobiliary to urological surgeries to colorectal surgeries to neonatal surgeries. All the cases are referred in Kenyatta. Actually, that's where our training is for University of Nairobi. We train in Kenyatta Hospital.
Yeah.
And that's where most referrals go to, everything you can think of. And my mentors, my seniors, are able to handle each and every subspecialty that would come with ease.
Yeah.
And we have good outcomes. So yeah, we're currently able to sort many things just here in Kenya.
I'm sure you're also aware of things that happen internationally in terms of pediatric surgery. One thing that I'm curious about, this is just my own, is there a difference, say, pediatric surgery in Africa versus, say, Europe or Asia? Like, if I'm a pediatric surgeon in Kenya, am I fine to go and just work in Europe or in Asia or wherever? Are there differences physiologically in terms of being African, being a different, yeah?
Thank you for that question. I must say I had the privilege of being in DC sometime in February, Children's National Hospital. And we just have the same cases.
Yeah.
And we operate, maybe what's different probably would be they have advanced equipments, which make it easier to work with. But in terms of the conditions or the surgical pediatric conditions they treat, they're just similar to what we have here back at home. So as a pediatric surgeon here in Kenya, whether you whether you travel to the US or UK, it's just the same conditions you still treat there. Maybe now what would be different, the burden of the disease in Africa might just be more than there, but the conditions are just the same and we treat them just the same. Okay. What advantage they have is just more advanced technology and equipment.
And probably healthcare infrastructure.
And the healthcare infrastructure.
Okay, when we get back on the Med Squad podcast, we're going to summarize this and try to lighten it a bit and get away from some of the very serious technical terms, but bring it a bit closer home. Stick around. Welcome back. This is the Med Squad podcast. My name is Yafesi Musoke, and I have Dr. Yvonne Olam with me, pediatric surgeon extraordinaire. Yes, I'm sure you've never had an intro like that. You can add that, extraordinaire. So actually, when you're in the theater, have you ever pictured yourself as a cartoon character? Which cartoon character?
Velma from Scooby-Doo.
Hey, you actually had one. Velma. Why Velma?
She's focused and she can solve mysteries under pressure.
Yeah. Yes. And which is your favorite comfort food after a long day at work?
Rice and minji.
Rice and minji?
Yeah.
Hey. You know what? That's your answer. I'm not even going to challenge that. But speaking of challenges, which has been your most challenging surgery ever?
I think the oncological patients, the children with tumors that we have to remove surgically. Those are the most challenging cases for me.
Yeah.
So there's a child with a bilateral Wimp's tumor. So just doing nephron sparing surgeries, I assisted in that case. It's a challenging procedure and also challenging for the child, the mom.
Yeah.
Yeah.
How many surgeons, what's the most number of surgeons operating on one child have you ever experienced?
It depends on where you are. It depends on where you are. We can have 4, depending on what is being done, depending on what procedure is needed.
Yeah.
Yeah. It's a technical procedure. You can have even more than that.
Yeah.
And you just take turns.
And is there a hierarchy? Like there's a head surgeon?
Yeah, there's always, because we do timeout, there's always a lead surgeon, there's an assistant surgeon, and also other assistant surgeons, and there's the nursing team. Yeah.
Okay. So which superpower do you wish you had?
I wish I could heal with a touch, so that children who have limited access to care or late referrals are able to just get healed.
Wow.
Yeah.
Hey, it's selfless. That's selfless superpower. What do you want your legacy to be in pediatric surgery?
Okay, my legacy. I want my legacy to be that there's no child who was denied surgery because of where they were born, and that faith, grit, and grace can rewrite the rules.
Yeah.
Yeah.
Hey, that's really cool. So if I just decided I'm benevolent like that, I give you $1 billion. What would you change? What would the first thing you try to change?
I'd start with Mbagathi and Mama Lucy. I work in Mbagathi.
Yeah.
So we'd equip our hospital. We'd build our pediatric surgical unit and extend the same grace to Mama Lucy.
Yeah.
And then other counties. Kenyatta is set. So that we don't have to refer all the time. And right now that we have a bit of issues with the bed capacity and the SHA issue, we're unable to refer patients. So now, and if you're unable to sort them out at our facility, where do we take them?
Yeah.
Yeah.
Okay. That's wow. So what would you say to, I guess, your final words on this, but also include aspiring health workers, people who want to be pediatric surgeons? Is this something that, are there, if I decide I want to be a surgeon, then now pediatric surgeon, is that like a separate set of qualifications, or is it like just a branch of surgery or on its own, or parallel bunch with the more stable hands?
Okay, currently it's a branch on its own. In Kenya, we do in University of Nairobi, because I studied my pediatric surgery in University of Nairobi. It's 5 years. So I think it has changed a bit, but the first 2 years we just do anatomy, then the second year general surgery, then from the third year we just join the Department of Pediatric Surgery, and then for 3 years we just train in pediatric surgery.
Yeah.
Yeah.
And this is after the initial just...
This is after you have done your undergraduate studies, of course.
Huh.
Yeah, you've already graduated, you're a doctor. Now you're doing your master's or postgraduate studies.
So the master's is done, that's 5 years.
Yeah, the master for pediatric surgery is 5 years.
Hey,
Mm-hmm.
thank you for the work you do.
Mm-hmm.
Hey, 5 years, your master's. On the Med Squad podcast, we have candid conversations about health and wellness across Africa. But we also show you how long it takes you to be part of the change in health and wellness across Africa. Pediatric surgery, you've heard it before. If you're a parent, trust your gut. Go ahead and trust the doctors as well. And if you found anything helpful on this episode, you know what to do. Share it. Please share the information. And also follow us on all our platforms at the Med Squad Pod. We'll see you next time.